Hello, everyone. I'm Dr. Josh Elo, and I got Dr. Kirk McCall with me today as we jump into a very cool, hot off the press study that just came out, American Journal of Psychiatry, looking at how do our typical antidepressants and psilocybin, how maybe do they work in depression? And so I'm really excited to have Dr. Kirk McCall. Uh, Kirk worked with me at Rush, and he was an instrumental in our psychedelic clinical trials as a therapist. And I am, as we're expanding into some new locations for our clinical trials for psilocybin, I'm beyond thrilled that Kirk is joining us to do more of this psychedelic psychotherapy. So, Kirk, thank you. Thank you for being here for us to talk about this, but also thank you for your work and saying yes when I asked you to to join us.
No, Josh, it's always good to see you and really good to talk with you about a very important topic. When we talk about psychedelics and the potential, I guess you could say, in terms of treating depression, but also other applications as well, it's something that I get excited about, really gets my gears going. So really excited to talk about this today with you.
All right, let's get the gears going. So why is this paper that we're about to talk about important? The mainstay, the first line treatments in depression are SSRIs. It's the first thing that we typically start when we're thinking about medications for somebody who presents with major depressive disorder. They are safe. They are effective. About 30% of folks on their first antidepressant tends to get into remission, more respond. Um, they are generally well tolerated, but they do have some potential for side effects. And as they've been out for what, 30 years now? I think Prozac came out like at the end of the 80s. Where we have some good evidence about how they work. However, one of the complications, I suppose, with SSRIs is that they can cause some emotional blunting that we see as a side effect, and not necessarily maybe at why they work, though partially, I suppose. Um, Contrast that with psilocybin, which we'll get into in a second, that is it work, although it's serotonergic, does it work in the same sort of way? And we'll talk a little bit more about the evidence there. But Kirk, in my experience working with patients with SSRIs, I tend to, have some good response with them. However, sometimes the people do feel like they're just a little bit blunted emotionally, just a little bit harder to kind of feel. Sometimes that's good in the negative space, right? But sometimes it becomes a problem.
Absolutely. And I can think of several cases, particularly one recently where somebody came in, started on a SSRI. And one of the things they've noticed is this emotional blunting, not just surrounding the depressive symptoms, but globally. It's very hard for them to engage in all the emotions, which, as you mentioned, can be helpful, especially when we're existing in that negative space for so long, dealing with these ruminative thoughts that really drive depression. But we just talk about the human experience overall and what it means to be human and be conscious and really engage with life in robust ways. Emotional response to situations is so important. So it gets me thinking about how we treat depression, what's really important when we talk about treating depression, and emotional blunting is certainly something we need to discuss more. And think the discussion we're about to get into really is going to outline that and show some alternative strategies on how we treat depression and how we deal with that emotional blunting.
So before we jump into the paper for today, I just want to set a little bit of the groundwork. This study that I put the title here was in the New England Journal in 2021, and it ran a trial, psilocybin versus escitalopram or lexapro for depression. Um, and the study that we're going to talk about is pulling more of the information from this really important study. But essentially, this study had two groups, and they looked at, does depression get better with time? So you can see from these bars here that the blue line are the folks who were randomized to escitalopram, and the red line are people who were randomized to psilocybin. The study was interesting because everybody went in for a psilocybin treatment uh, uh, on day one, and then 3 weeks later, half of them ended up getting the psilocybin, and then half of them did not. The ones who did not ended up getting escitalopram, but the patients or the subjects didn't know which arm they were randomized to. The therapists working with these subjects didn't know what arm they were randomized to, and then the raters who were looking to see if there was changes in these scores were also blinded. So that's a typical way that these studies have been run in order to try to minimize any of the extra effects to see us being unblinded and therefore our own biases kind of influencing what we think should happen, whether it's actually showing up or not. So this first panel here is the QIDS, which is a typical scale for depression. And you can see in the blue line after day one, which is when people came in for the first dosing or started the escitalopram, folks started having a reduction in their depressive symptoms in both groups, thankfully. But you can see that in red, you actually early on, less than a week in, you see that you're starting to get a separation from of psilocybin relative to escitalopram. And then that separation maybe isn't quite as big, but it persists throughout the study. You can see here that at week 3, there's another psilocybin dosing. People continue to be on their escitalopram. In fact, for the first 3 weeks, they're on 10 milligrams, and then when you get to that second psilocybin dosing, the people randomized to the escitalopram go up to 20 milligrams. And so then by the end here, day 42, there's still this separation. Those error bars, those little points where the lines are reaching out toward each other, they do cross over. So it ultimately, like statistically, suggested that they didn't quite separate enough, but there definitely does seem to be a trend here.
Absolutely. And I think that's an important note that we're seeing that trend, even though it's not statistically significant at the end of follow-up period. And this is something that we wrestle with when we're talking about psychedelics, not being too overly eager, you might say, in interpreting the results. One of the troubles we run into with these studies, blinding, trying to maintain that blind, which is difficult for the study subjects as well as the investigators. And so there are a lot of things that play into what we're seeing with this response. Something else we talk about as study therapists is how to really optimize the delivery of the therapy.
Mm.
In actual practice, there are a lot of things we can do to make the therapy more robust. The model we provide in these studies has to be standardized. And from client to client, you may notice things that could be a little bit different outside of the standardized model that could augment the effect of what the study drug is doing. But then that speaks to the question, is it the study drug, the synthetic psilocybin that's providing this effect, or is it the therapy, the delivery, the preparation, the integration work you're doing? Regardless of all of those points, we do see some of this separation, which is really exciting. And it speaks to what we've known intuitively for a very long time as humans, that psychedelic compounds really can be beneficial in addressing mood disorders, particularly depression. And this outlines that pretty well.
Yeah, yeah. And to be clear, like both of these arms, in an effort to try to minimize any of that unblinding, both these arms ended up getting the same kind of model. The one that Kirk, you explained really well about the preparation and the integration. Even if you got escitalopram, you still were going in kind of as if you were getting a psilocybin dosing and working with the therapist in that sort of way. A real active debate, especially right now in our field. It has been for a while, but I feel like lately there's been a bit of more of this discussion. Is okay, we got symptom control, but what about wellness? What about well-being? What about functioning? And I think this study realized that's important and added in this other scale, which is really, it's called the Wem-Wibers. I don't know, that's not what it's called. But it is looking at wellness and it's looking at functioning. And here, same lines correspond to each of those treatment arms, same scale, same study, right? But you're seeing here that this study, this scale, as opposed to wanting to bring depression down, which is what the QIDS is looking at, this one's like, hey, how's your wellness? Is it getting better? And so up is good. And here you see a pretty clear separation that in the psilocybin arm, there was quite a bit of an improvement relative to the escitalopram.
Yep. And what really gets me excited about psychedelic work And it's kind of changed how I look at depression, how I talk about it with my patients, is looking at these secondary measures.
Yeah.
Uh, a lot of what I talk about with patients when we're trying to figure out what matters to them when we treat depression, it's oftentimes not the primary measure that we're looking at in these studies. Sometimes it's like, I want to feel more well. And when we really dive in and ask what that means specifically, like, well, maybe I just want to be able to read more, enjoy time with my grandkids, or enjoy the sporting event I'm going to. And we might still see some of those lingering symptoms of depression that are identified in the primary measure, the endpoint that we're really trying to target. But those secondary measures speak more to what certain patients might want. And we're seeing that statistical significance here with psychedelics.
Yeah, I like the way you put it a little bit earlier, Kirk, was I forget what exactly you said, but essentially like the fullness of life, and depression, like it robs that. And certainly these symptoms are getting in the way. But if we think about it maybe a little bit more uh, comprehensively, then wellness and satisfaction, quality of life are going to be important parts of that.
Absolutely.
All right, without further ado, let's get to this study. So this one was, like I said, just published. It grabbed the data from that study that we were just talking about with those outcomes. But part of the study was looking a little bit more at some of those secondary outcome measures, as well as brain functioning via fMRIs. So this is pulled from that data, and like I said, it's randomized. They're double blind, which means the patient doesn't know, the raters don't know like which arm they got sent into. They ultimately had 30 folks in the psilocybin arm and 29 in the escitalopram. Everyone had these two dosing sessions, like I had mentioned before, whether you were actually getting the active drug or not. And then the psilocybin folks were getting 25 milligrams of synthetic psilocybin, and then the others were not getting that dose. And then everyone took a pill daily. The ones that weren't getting the psilocybin, it was escitalopram. The ones who were getting psilocybin, they were getting placebo. So then this was a 6-week study, and then those dosing sessions, as you saw in that previous uh, chart, were 3 weeks apart. Now they did an fMRI study. So for those of you who aren't aware, fMRIs are going to be scans of your brain, and they're looking at blood flow in different areas. And this is a really interesting place, especially in psychiatry. It's really unlocked some of the ways that we start thinking about some of our disorders and looking at some of the structures that we know are really important for emotional processing. And so this study used that imaging modality and did scans before people were randomized to either treatment arm, and then did them again at 6 weeks, essentially after the full treatment of either the escitalopram or the psilocybin. And what they did is when they were in the scanner, they weren't just looking to see kind of about spontaneous. They were trying about spontaneous like blood flow changes. They were trying to evoke maybe some ways that people might experience emotions. So then what happens is you're in the scanner showing in real time what's happening with the blood flow in your brain. And then the study staff will show you pictures of different kinds of faces. They'll either be positive, neutral, or negative faces. And this is all kind of about the motion. So maybe negative is going to be more like somebody looks angry or is crying or feels really anxious. Neutral is going to be, obviously pretty neutral, and then positive, smiling, having fun with their kids, these sorts of different emotional images. And then looking at how do people process what happens with the blood flow when people are shown these images and different parts of the brain. So I want to show some outcomes here. This is looking at these two arms. To orient you, the escitalopram is going to be in green, and then the psilocybin is going to be orange. Different journal, different color scheme, different way that the graphs are going to look. And this first one here is looking at the quids, the same scale that we saw previously. But this is important to note that it might look slightly different here because not everybody was able to get the scan. This presentation is just barely different. It's the same patients in general, but it actually was done during like right as COVID was beginning. And so some of the post scans weren't allowed. So some people weren't able to be involved. It's still very good numbers, but that's why it looks slightly different. Anyway, in this group, you're seeing a little bit more convincing of a separation in the quids, which is, remember, down is good. We want less of the depression. And orange line is pretty clear with those error bars that they're separating from the escitalopram. BDI, this panel over here to the right, is another way to look at depression, kind of verifying that, yes, the quids showed a difference, and this other one, the Beck Depression Inventory, also showed a difference. Let me jump to the next one, because again, we're going to see here that the well-being score, again, even in this population that just barely deferred, the same story is the same. Wellness was better in the psilocybin study arm relative to the escitalopram. And now here's where we get some new stuff that might be interesting. Clinically, Kirk, I know that anhedonia, the struggle with being able to experience positive emotions, is such a difficult piece in depression. So this SHAPS score is a scale looking at ability to enjoy things. This is a scale I've started working in my clinical practice with, just trying to get a sense of like, are you able to enjoy time with family? Do you enjoy like a good meal? Living in Chicago, going out to a good restaurant, like, do you like it? Like, are you really able to get excited about it? And you can see here that obviously we want less anhedonia. We want people to be able to enjoy things. And here we're seeing a, consistent with the rest of this, psilocybin is separating from escitalopram.
Absolutely. And it's so important when we talk about how people live their life with depression. And going back to what we were talking about earlier, like these primary outcome measures, while depression may improve, if you're not really enjoying the experience of life, for certain individuals, that may be more profound than some of those primary symptoms that we would normally want to see improved. And anhedonia certainly fits into that category, but seeing that separation here is pretty incredible, if you ask me. And we'll look at some of the images that correlate to certain brain regions where we're seeing emotional blunting or lack of thereof. Not to jump the gun too much here, but this I think it's really important to keep in mind anhedonia and how it may correlate to those images as well.
Yeah. Um, and then here's a couple more of these secondary outcome measures that I think are kind of interesting. So we mentioned a little bit about this emotional blunting, this LEIS score, which is on the left panel, is looking essentially at that, the emotional intensity, not just positive, not just negative, kind of all emotional intensity of different situations, I suppose. And you can see here that in the orange, the psilocybin arm relative to green, the escitalopram, that you end up showing a little bit less in the green relative to the orange. Again, suggesting there's like some sort of group effect here with the emotional intensity. Now, the sexual dysfunction part is an interesting one here. We know that though our SSRIs are useful in the treatment of depression, they are not biologically inert. They exert effects, not just for the good stuff, sometimes for the side effects. And so in green, you can see more of the subjects reported sexual dysfunction problems, consistent with what we know about SSRIs and less with the psilocybin. It might be a little bit difficult here, but essentially at the 0 line, you can see there's a lot of points of orange, suggesting that many people had none. Some in the escitalopram also had none, but then more, as the scale goes up, you can see more in the green relative to the orange. Let me jump to the good stuff because we've been biting our tongue. We've been trying our best not to get excited. Let's look at some brains. Kirk, you know that I love brains, and one of the greatest travesties, at least yet, maybe we're getting there, is how our field has not been able to really get into looking at the brain at an individual level to really get a sense of how can I get this person feeling better as soon as possible. Work like this helps us unlock a little bit more of this and help folks really understand what's going on with these treatments, with these disorders, and how do these treatments work? And I think it really takes a lot of the guesswork out. So this is why I said, Kirk, we got to do this paper. And so thanks for indulging me. So you can see in these brain scans here, we're at the level essentially kind of maybe let's say it of the eyes or so, and these scans you're taking slices throughout here. So that's important to orient that we're down here because these little areas that are not gray and white and black, but instead they're red, yellow. This is the amygdala. This is an almond-shaped little structure deep down in the limbic part of your brain, kind of the reptilian part of the brain, as some people would say, that's really important for fear processing and emotional processing in general. But we think about it a lot, certainly in our mood disorders, definitely in our anxiety disorders, kind of a whole host of things. So what we're looking at here is this is specific to just the escitalopram arm. And we're looking at the difference in the signal. So we get these pretty pictures, which is good, but really the data is over here on the right panel, this B panel, where you can see now here we're in the different parts of faces that showed up. We have the fearful faces and the neutral faces. In escitalopram, the green is going to be after, the black is going to be before. So we're kind of moving along linearly with time. And in the fearful faces, you can see that the amount of activity in the amygdala decreases with the treatment to the point where you can see the star above it. It's saying this is statistically significant. There is definitely a change in how much blood flow is getting to that part in this arm. Now, going over a little bit more to the right, the neutral faces, you can see the trend is like suggesting maybe it's also going that way, like less of the blood flow in the amygdala with neutral faces, but it doesn't have the same star like the fearful one does. So not as convincing about there definitely being a statistically significant difference.
And when I see this, what I think about, the paper dives into this a bit as well. Uh, this reduction, this blunting, is this more indicative of lingering depression symptoms? Or is it really something happening on the receptor level, particularly looking at the 5-HT1A receptor and some of the inhibition that can cause in these areas? And one of the important points to note here, and this is the distinction between an SSRI treatment and a psilocybin treatment. In this case, that inhibition at that receptor and the emotional blunting that's likely resulting from that, this points to more efficacy with SSRIs when we talk about treating depression. So it seems counterintuitive here, but that emotional blunting that maybe we don't want, when we talk about depression and the outcomes, it's more efficacious when we get that blunting here, as opposed to psychedelics, which we'll see in a second in the future slides. We see a little bit of a different response there.
That's a good point because this is not necessarily bad. This is something I talk about with my patients a lot because this is not the first paper to show that SSRIs can have this difference with the fearful faces, right? So this is something that we've known. And frankly, when your depression has a lot of anxiety to it and it's like a real struggle to get out and do stuff because of fearing of how you're going to be perceived or worrying about, being able to make conversation or all those things that might provoke a little bit of anxiety, there's a real utility in kind of blunting a little bit of that fearfulness response because it can be so inhibitory to being able to engage in life. So I will say that sometimes this is a part of what we need. And so, but is it necessary? Is it sufficient for the depression? Is it the only way to get in there? If we're only going to get about a third of folks who are going to get into remission with SSRIs, is this the only way to sort of to do this work? With that in mind, yeah, let's look at the psilocybin. So you can see now this is all the psilocybin arm, and you're actually these scans over here on the left. You're not seeing a whole lot lighting up in the amygdala like you did with the escitalopram, right? You're seeing some changes in blood flow, but it's not that like reliable spot that was in every single scan. And I think that if we look over here to the right, that is consistent. Neither of these you can look right away if you're a cheater like me and see if there's any statistical significance. There wasn't, and you can see that oh yeah, there's not necessarily a trend even that people are having less signal in the amygdala with this treatment.
You wonder about the emotional blunting and the value of it and the lack thereof here, particularly with fearful faces. One might think that if we're not seeing a reduction in the emotional response to that, isn't that intuitively not a great thing when we're
Mm.
talking about outcomes here? How I like to think of this when we talk about psychedelics, they allow you to make more space for some of these emotions, some of these responses we may perceive as negative. you're able to interact with those emotions in novel ways that we really don't truly understand yet. It's one of those if you know type of thing. People who have experienced a psychedelic, what they'll tell you is, I have this flood of emotions. I'm experiencing everything all at once. And it's very difficult to interpret that in the session during integration sessions when we talk about what happened and try to make sense of it. One thing that I find is people will talk about these negative thoughts, these negative emotions differently. There's not an avoidance there, there's a curiosity. There's a desire to dive deeper and understand more, as opposed to blunting the emotion and not dealing with it. So, in reality, what's happening at a biochemical level is we're seeing this lack of blunting, and how does this manifest in our clients? There's more of a curiosity to engage with all of these emotions and make space for all of these emotions, which really starts to get at some of the core root causes of the problem surrounding depression.
Kirk, I think that's really something that I wanted to ask you a little bit more. As somebody who's in that room, who's doing this work, um, if we're moving away from, okay, let's kind of like take some of the bad out to make it easier, and instead we're kind of leaning in. They talk about this in the paper, though it wasn't statistically significant. If you look at this neutral faces side, it actually maybe trends a smidge up. And so, and some of the previous work in psilocybin actually showed that maybe there is more of a response, a positive response, not a decrease in the blood flow, but maybe even a good thing or an increase in the blood flow, I should say, with psilocybin. My question is like, um, does that what does that mean kind of clinically? Like, is that something then, oh, I really want to have this person kind of in that experience, and then how do you kind of guide as a therapist along that way?
Yeah, so I think a lot of it goes back to the preparation work. We talk a lot about what happens during session. We talk about integration and trying to make these new insights that come up mean something in your day-to-day life, which can be extraordinarily difficult because for some folks, there's a lot of content that comes up. But going back to the preparation work, we talk about an intention going into the session. And for most folks coming into a TRD trial, superficially the intention is, I want to get rid of my depression. I want to feel better. What
Yeah.
does that mean? And when you start to go beneath the hood, you find out that it looks very different for folks. And a lot of it centers around negative content that's been deep rooted, suppressed, or repressed, sits around these negative emotions. And how I tend to look at emotions, good or bad, they're all part of the human experience. And when you look at them from that through that lens, no emotion is truly negative. We don't want it to lead to occupational impairment, whether that's the deep lows of depression or the extreme highs that you might see with a hypomania or mania. We want you to be right in the pocket, but still experience all of that. And from a clinical standpoint, that's what I talk about a lot with my clients. Let's not try to blunt the experience. Let's understand it. And if it's really causing impairment, let's engage in a treatment modality that's going to target that. But what's most important is to be able to experience the full range of emotions, because when you can do that, it makes it much easier to go through life, appreciate life. And I think that's what you're seeing, particularly when we talk about the neutral faces and an increased response there with psilocybin. Under normal circumstances, one might think it's neutral, who cares, right? This means nothing to me one way or the other. With the psychedelic, when it starts to enter the chat here, what we're seeing is a greater appreciation for everything, greater connection with everything. And I think that speaks to something that we're just now starting to talk about, just now starting to understand this greater connection between all of us, which plays into consciousness and what that really means. So, psychedelics, and they're kind of pushing us towards this higher level of consciousness and session. And what we're seeing is not just an ability to address depression, but an ability to expand how we think about life. And
Mhm.
for me, that's what really gets exciting, having the opportunity to help people make those sorts of realizations.
That's so well said. I think you're right. Like if you're going to, we talk about psilocybin and some of the psychedelics as being these sort of rapidly acting antidepressants, and I think that biologically, perhaps that's true. They're pretty quick subjective effects, but it really begs for the prep to really know, okay, if this is going to happen, what are we going to do with it? The integration of like, okay, now what are we going to do with it? And it really just it's a great reminder, Kirk, the way you said it about how much of this work is necessary to put it in the right context and get the most out of it. Because you're right, if you're going to change your perception, um, and I mean, we see it quite a bit. People are feeling so crummy for so long, like the depression and the self, like it can sometimes get so intermingled. Like we're really going to change through, break some of those patterns, change some of the ways that's showing up in your life. We need to get ready for it because it's a big change, and then we need to recognize like how are we gonna work with this change kind of going forward.
Absolutely. It's difficult work. And integration is, I view it as a lifelong process. It's more profound, more robust than just a few sessions after dosing. You may be walking down the street one day, several years after a psychedelic experience, and you see something, hear something, smell something that reminds you of emotions that came up. And now we're really starting to think. Now we're really starting to get it. We're really starting to connect uh,
Hmm.
with things around us, with life in general, and that's something that we don't necessarily see with treatment as usual, as it's applied now. The blunting, while appropriate for certain individuals, and as an aside, I have clients who experience that and they say, "This is the best I've ever felt." I'm able to really engage in life in ways that are meaningful. Um, have other folks who have quite the opposite experience. So I think that's the intersection of psychiatry here. Being able to appreciate the nuances of treatment, have a curated treatment plan that caters to the specific needs. Psychedelics I think are very beneficial, very powerful tools. Um, and there's something that have been a part of our society for thousands and thousands of years. So none of this is new. We're able to quantify it more and try to understand what's happening. But um, I say that to say you have to approach them with caution. I think that for certain individuals, you can do harm if you're not really taking a robust approach to treatment. And the same goes for SSRIs and treatment as usual. You really need somebody who understands those nuances to kind of help interplay and make sure that we're getting to the best version of ourselves with treatment.
Yeah, I think that'll be really interesting one day, hopefully soon, when we have this in our armamentarium in our clinical work. Until then, we're currently running these studies. We're down at Rush. Put the number here just in case you or maybe somebody that you're working with or somebody who hasn't had the best response to the antidepressants might be interested in getting involved in our clinical trials for psilocybin. As Dr. McCall was mentioning, there's several inclusion, exclusion things to think about who's appropriate and safe, and really like focus primarily on the safety. But down at Rush, we're running it. We have recently expanded, as I was mentioning, and so Dr. McCall is helping us up in Skokie at Psychiatric Medicine Associates, also running a psilocybin study. So, with that in mind, Dr. Kirk McCall, it has been a pleasure talking with you. Thank you for taking the time, your expertise. I mean, your ability to recognize like the role of the therapy and how these are working. I mean, it's just fun. I'm glad I got to say a couple things, but seriously, like you shone through on this video. Thanks for your help. I appreciate it.
Absolutely. Thanks for having me. And, really, really great to talk about an important topic. And, I feel like every day you're hearing new information about psychedelic therapies and how they can be applied. So being able to be on the cutting edge and really provide treatment for folks who are needing it, who haven't responded to medications and treatment as usual, it's a really good spot to be at.
Yeah. All right. Well, until next time.